This is a really great example of how the Serenator can be used to treat multiple different sizes and multiple different locations of tibial vessels. This is a 65-year-old gentleman who presented with a history of poorly controlled diabetes, chronic kidney disease, and gangrene with active cellulitis associated with his first toe down to the base of the first metatarsal. He had been non-compliant with medical therapy for some time, and as a result, he had gone on to have pretty significant tibial disease. He had no pedal pulses present on physical examination and only weak Doppler signals in the DP and PT distribution. If you look at his below-the-knee angiogram, you see that at the proximal tibial vessels, the anterior tibial artery is occluded, the peroneal artery has multiple tandem high-grade stenoses, and the posterior tibial artery proximally is patent, although likely undersized. Going down into the foot, you can see that the peroneal gives off some collaterals with late filling of the plantar artery, but that otherwise the posterior tibial artery and the anterior tibial artery are occluded. We went in with the Serenator and we were able to successfully achieve inline 2-vessel flow by treating the PT as well as the peroneal artery. For the PT, we pre-dilated the distal posterior tibial artery and common plantar artery using a 2mm balloon, followed by 2.5 by 120mm Serenator balloon angioplasty at less than nominal pressures. You can see on the completion angiogram result, restoration of flow in a previously occluded distal PT with good runoff flow through the plantar vessels and no evidence of significant or flow-limiting dissection. Going up to the peroneal artery, we treated this without predilation with a single 3mm by 120mm balloon across these tandem stenoses. Again, this was inflated to less than nominal pressure, and we achieved complete expansion of the balloon with that. Completion angiogram in this area shows a really robust peroneal artery at this point with no evidence of dissection and great flow, again preserved distally. This case was able to be completed in less than an hour, and the patient went on to have a first toe amputation, which he subsequently healed without issue. I think to me this really underscores the value added by using serration technology. This allowed us to deliver really robust flow to this patient at a time when they needed the ability to heal their wound and when they might have had some other contraindications to performing a more aggressive bypass, such as their medical risk factors as well as the active infection present at their toe.